Hello everybody. Today we are going to discuss a very interesting topic, that is extracorporeal blood purification. So we have this 64-year-old male patient who is a known case of hypertension, diabetes mellitus, ischemic heart disease. He came with chief complaint of abdominal pain, burning micturition, and fever with chills since 3 days. On arrival in emergency department, patient was hemodynamically stable. So all routine blood investigation was sent along with urine routine. So urine routine showed plenty of pus cells. So we have started him on cefoperazone sulbactam. Next day, patient developed hypotension and then required NORAD support. Blood investigation showed deranged RFT, deranged liver function test. INR came out to be elevated, and patient was diagnosed with sepsis with multi-organ dysfunction. So what is sepsis? And we'll understand what is sepsis and what is the pathophysiology behind this sepsis with multi-organ dysfunction. So sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to the infection. So this new definition arises from the improvement in the understanding of the sepsis pathology. So the first step in the infectious process is the recognition of the pathogen by the immune system. So this all pathogen exhibit on their surface specific component known as pathogen-associated molecular patterns such as endotoxin, which is expressed by the gram-negative bacteria. During infection, this pathogen-associated molecular pattern are recognized by the pattern recognition receptor expressed at the surface of immune cell. This signal activates these leukocytes, which induces the synthesis of pro-inflammatory, anti-inflammatory cytokines, including tumor necrosis factor alpha, interleukin 1, interleukin 6, interleukin 8, and interleukin 10. So, because of this massive release of the cytokine in the blood, uh, this this is known as this is described as cytokine storm, which is responsible for the or multi-organ dysfunction. So this injured host cell express on their surface damage associated molecular pattern like high mobility group box 1 protein. So this damage associated molecular pattern may be released in the circulation and are recognized by the pattern recognition receptor that thus enhancing leukocyte activation and cytokine synthesis, which is fueling the vicious circle of uncontrolled immunoinflammatory process. So after this initial cytokine storm, the immune paralysis state occurs, contributing to the most of the sepsis associated death because of the healthcare associated infection and the viral reactivation. So the better understanding of this mechanism and the underlying pathophysiology behind this sepsis with multi-organ failure has permitted to the development of the new immune therapies to modulate this immune inflammatory response. So the promising results have been obtained with the new molecules such as recombinant human interleukin 7, and the another approach consisting of removing this non-specific broad spectrum inflammatory mediators, and this is now possible with the help of extracorporeal blood purification device. So most of the extracorporeal technique interfere at one particular step of complex immune process, but some of them may have two or more targets. So first, they may decrease the cytokine concentration under toxic threshold in order to limit the local deleterious effect of cytokine. And another target of the blood purification technique is the inhibition of the immunoinflammatory cascade trigger. So the objective is therefore to remove pathogen and the pathogen associated molecular pattern such as endotoxin before they activate leukocyte. Finally, the modulation of the immune process may directly involve the leukocyte, either through their direct removal or through the immune cell reprogramming. That is, they will modulate the surface marker expression, there will be the improvement in the antigen presenting capability or adjustment of the apoptosis. So we'll see the blood purification targets of the blood purification technique. So first they will remove the pathogen from the blood. Then the second, they will remove the endotoxin and the other pattern, this pathogen associated molecular pattern. Then third, they will be removing the activated leukocyte and reprogrammed leukocyte. And the fourth, they will help in removing the cytokines, which will reduce the cytokine storm and its consequences. So the various extracorporeal purification therapies were proposed as an adjunctive treatment designed to modulate inflammatory response. So in this lecture, we'll learn what are these extracorporeal techniques and how we can use it for the sepsis. So we'll see the different mechanism of this technique. So for a few techniques they will remove only endotoxin. So one of the most widely used endotoxin removal therapy is the absorption with the polymyxin B immobilized fiber column. Then the next techniques, they will a few techniques they will remove only cytokine. So the techniques like high volume hemofiltration, it is the continuous renal replacement therapy with high ultrafiltration rate that is more than 50 ml per kg per hour, and it offers the enhanced removal of hydrophilic middle weight molecules. And the next technique which are which are targeting cytokine is the high cutoff membrane with continuous venovenous hemofiltration to improve the cardiovascular parameters in septic patient, but at the cost of massive albumin leakage. And the next technique is the coupled plasma filtration absorption, which is the blood purification technique in which first high cutoff membrane is included at the beginning of circuit and which separates the plasma from the blood. Then the next is cytosop technology. It is a hemoperfusion cartridge filled with the polymer beads that can absorb pro and anti-inflammatory mediator but not endotoxin. Now, these cytokine absorbing hemofilters are primarily designed for RRT, but the material used to build the membrane may also offer absorbing properties that can be used for the blood purification. Then the next is polymethyl methacrylate membrane. It is a synthetic polymeric membrane with symmetric microporous structure. Now, few techniques are targeting the removal of cytokine as well as endotoxin. And the improvement of the industrial process led to the development of the oxidase membrane, which is the heparin grafted membrane specifically designed for the cytokine and endotoxin reabsorption along with RRT. So we'll see one by one this all this technique in detail. So first we'll see the high volume hemofiltration and very high volume hemofiltration. So this high volume hemofiltration is defined as continuous uh, treatment with convective target dose, which is greater than 35 ml per kg per hour. If this dose is greater than 45 ml per kg per hour, then it is designed as very high volume, very high volume hemofiltration. As a technique, it has been utilized for the immunomodulation in context of both ACE and sepsis. So this is the diagrammatic representation of the high volume hemofiltration and the very high volume hemofiltration. Now the technical aspects. So high volume hemofiltration and very high volume hemofiltration are easily implemented in the center, which are capable of performing conventional CRRT, but no additional component to the usual circuit is needed. So dialyzer that we are using is high flux dialyzer that is more than 25 ml per hour per mmHg per meter square. The blood flow rate that we are using is they have high ultrafiltration rate. So required blood flow typically must guarantee no excessive filtration fraction values. It should not be not more than 25 to 30%. And it is a dose should be greater than 35 to 45 ml per kg per hour. And the overall dose can be higher, which is 50 to 70 ml per kg per hour due to complementary diffusive component that is continuous venovenous hemofiltration. The replacement fluid is used in the pre and the post dilution mode. For given target dose, it is necessary to consider the pre-dilution replacement fluid must be higher than the post-dilution, and the duration is according to the patient's condition. Anticoagulation that we are using is heparin or citrate. So these are the various studies which are published in the demonstrating the effectiveness and the limitation of the high volume hemofiltration. So among this study, the only large and the only multi-center RCT to the date was Ivory trial. And it should be noted that the different protocols were used with the doses ranging from the 40 to 70 ml per kg per hour. So earlier observational studies have suggested the mortality benefit and the improvement of the hemodynamics, but the only Ivory trial showed the no difference. So the overall result of this trial are inconsistent. So the next technique is the high cutoff membrane, which is characterized by the large pore size of average of the pore size of 20 mm compared to the standard high flux diameter that is 10 mm. So this high cutoff membrane use is similar to the standard RRT prescription, including the choice of anticoagulation. And the prescribed dose is in the form of 25 to 40 ml per kg per hour as recommended by the KDIGO guidelines. And the convective modalities would maximize the high cutoff membrane ability to remove the pro and anti-inflammatory mediator. But the disadvantages with this technique, there will be the loss of excessive albumin is observed with the use of such a membrane, and it dictates the utilization of only diffusive modalities. So the use of high cutoff membrane is not limited to the sepsis, but it is also used in the management of the AKI patient with rhabdomyolysis and multiple myeloma. This is the diagrammatic representation of the high cutoff membrane. So regarding this high cutoff membrane, the various trials are published. We'll see what are these studies. So in 2003, 4, and 6, the Morgera et al. They have published trial which showed there was a successful elimination of the interleukin 6, interleukin 1 and 6, and there was the reduction in the vasopressor level. Then Hess et al. Published the trial study in 2007, which showed the decrease in interleukin 6, 8, and 10. Then Chilazzi et al. Published the study in 2016, which showed the reduction in ICU mortality and improvement in overall hemodynamics. Then in 2016 and 2017 also, the studies were published, which also showed there is a reduction in interleukin 10, 11, 10, 12, and TNF alpha. So we can see there was an overall mortality benefit of this high cutoff membrane. Then the next is the absorption. The terminology absorption is performed in the form of hemoperfusion, plasma perfusion, and coupled plasma filtration absorption. So hemoperfusion involves the passage of the blood through hemofilter where mediators are absorbed to the membrane surface and through sorbent containing cartridge. So we'll focus on the use of absorption in sepsis. However, it also been studied in the context of cardiopulmonary bypass surgery and other conditions. In sepsis, it is generally advocated for treating patients with suspected gram-negative sepsis or septic shock. Now, the technical aspect, absorption can be used in the isolation or in combination with the HD or continuous veno-venous hemofiltration. More than one session is often required to overcome the possible rebound. Now, the prescription depends upon the absorption cartridge used and should always be guided by the user manual. This is a rapidly evolving area and will focus on widely used cartridges. Now, the cartridges are polymyxin B immobilized fiber column. So this polymyxin was used, polymyxin B was found to be largely safe. Thrombocytopenia, leukopenia are common, but generally not clinically significant. So these are the various studies, various trial, which was published in which describing the effectiveness and the limitation of the polymyxin B immobilizer fiber. So we'll see the conclusion of this trial. So all studies showed the reduction in the mortality, reduction in the length of ICU stay, improvement in the hemodynamics, and the no significant changes in the interleukin 6. Then the next is the cytosob. The evidence of cytosob is limited to the case report and series and few RCTs, but it is a growing. Observational data suggests the improvement in the hemodynamics and trend towards decreased mortality. And it is also found that there is a reduction in the interleukin 6 levels. So these are the main trials which was published in regarding showing the demonstrating effectiveness and the limitation of the cytosob cartridge. The conclusion of this trial was there was a reduction in the ICU mortality, improvement in hemodynamics, and significant reduction in the vasopressor. So one drawback of the cytosob, it does not capture endotoxin and the interleukin 10. So the heme absorption that we are using cytosob reduce the level of broad spectrum cytokine, then damage associated molecular pattern, pathogen associated molecular pattern, and mycotoxin more than 50%. Because of the unspecified mediator elimination properties of cytosob, it has been widely studied in the context of cardiac surgery. Now the next absorber is HA330. In the context of sepsis, two small RCTs describe the effectiveness of HA330 in decreasing inflammatory mediators along with improvement in hemodynamics, mortality, and ICU length of stay. One of the trial was conducted in septic patient with acute lung injury, in which there was marked improvement in the respiratory parameters in the HP group. So the main studies were published describing the this effectiveness and the limitation. One study was published by Hung et al. In 2010, and the another study was published in 2030. And the conclusion of this trial was improvement in the hospital mortality, reduction in the vasopressor dose, and the significant reduction in interleukin 1, 6, 8, and TNF. Then the next is Oxiris. In the study reported by Shun et al., the Oxiris CVVH was delivered to 6 patients with septic AKI, and the results were compared to 24 severity matched historical control undergoing standard therapy. And the result of this result demonstrated that SOFA score was reduced after 48 hours CVVH from the value at the time of ICU admission by 38% in Oxiris group, while it was increased by 3% in control group. There was no significant difference observed in the ICU and in hospital mortality. Then the next is LPS absorber, which was obtained from the case reports and series, and that showed decrease in endotoxin level as well as improvement in patient hemodynamics with no significant side effects. So these are the studies which was published showing the effectiveness and the limitation of LPS absorber, which was so one study was published in 2009, the next in 2011, and after that in 2015 another study was published. And the overall conclusion of this trial was it showed decrease in endotoxin level and improvement in the mortality. So the next is coupled plasma filtration absorption. So the coupled plasma filtration absorption is the combination of separation of plasma from the cellular component of the blood with highly permeable membrane, followed by the sorbent absorption of the plasma component with the stearin resin to remove number of different cytokine, and then re-infusion of purified plasma before hemofilter to finally simultaneously provide CRRT for renal and fluid supply. So the advantage of the CPFA is the lack of direct contact between the blood cells with sorbent material, which lead to the improvement in the biocompatibility. This is the diagrammatic representation of the CPFA. Now the technical aspect, the blood flow rate is 150 to 220 ml per minute. Plasma flow rate is the 17 to 20% of the blood flow rate, that is 35 to 40 ml per minute. Ultrafiltration rate maximum 2500 ml per hour, and the replacement fluid is usually provided into the post-dilutional mode. Now the duration daily for the 5 days lasting for more than 10 hours per day. Anticoagulation, the typical anticoagulation used is heparin, but citrate has been used safely and may represent attractive alternative given the high rate of clotting with CPFA. The effectiveness of CPFA is dose dependent, and the volume of plasma cleared in the dose of 0.8 liter per kg per day is typically associated with a better outcome. The evidence for the use of CPFA is largely derived from the small observational study, which suggested no benefit in terms of survival, ICU length of stay, but potential improvement in the hemodynamics, interestingly in the dose-dependent fashion. The largest trial regarding this to the date is compact trial involving 192 patients randomized to either standard care versus CPFA plus standard care, and there was no difference in the hospital mortality. This is the diagrammatic representation of the coupled plasma filtration absorption. Now we'll see what are the complications of this blood purification technique. There is always risk of bleeding, then clotting and the changes in anticoagulation requirement. Then there will be the drop in the platelet count. Catheter-related complications can also occur. Also common to all technique is the important issue of the drug removal. So additional antibiotic doses may be required. The unpredictable loss of beneficial molecules such as albumin, especially in the high cutoff membrane use, the other nutrient and the amino acid is important to take into consideration. Then the next complication is electrolyte imbalance, hypophosphatemia, hypokalemia, is noted and could be harmful, particularly in the critically ill patient, and should be carefully monitored. And the risk is more pronounced in the high volume hemofiltration technique. As technique-specific adverse event, the absorption is associated with thrombocytopenia, leukopenia, and high-volume hemofiltration places the patient at risk of hemodynamic instability and hypothermia with high convection. This high-volume hemofiltration also results in increasing nursing workload, which can lead to the possible introduction of error. With regard to the its high cutoff membrane use, the albumin loss is particularly significant in comparison to other techniques. This can be minimized by applying CVVHD, as convective clearance is more with albumin loss compared with the diffusive clearance, with increasing the effluent flow to increase the cytokine clearance. Thank you guys for patient listening.